we would be going into discussion.
Yeah.
Once his presentation stops, we would start with discussion.
Okay. Good evening, friends. This is Dr. Rajkumar here.
Keep on joining.
On behalf of IPS Vadodara, I welcome you on this evening for a case-based discussion on negative symptoms and treatment-resistant presentations. Dr. Nachiket Desai will be presenting the case. Dr. Malay Dave as well as Dr. Bhaskar Mukherjee will be taking it forward into discussions. Over to you, Dr. Nachiketa.
Thank you, everyone. I'm Abdul.
You're already the co-host, Nachiketa.
Yeah, so I'll be sharing my screen.
Yeah, do it.
Hello.
Just a minute. Yeah, so today we'll be trying to understand negative symptoms and treatment resistance from the neurobiological point of view.
Nachiketa, your audio is not very clear.
Hello, is it better now?
Nachiketa is joined through mobile and the internet is not good there, and you can see the
Nachiketa, your voice is sounding muffled.
Hello, is it better now?
It is better, but it is still muffled. So it shouldn't go away in between.
Sir, please check your internet connection. Nachiketa, sir, check your internet connection.
Yes, it's been checked, and I'm in
your internet is not good.
So just give me 2 minutes. I'll stop screen share and restart again in a few bits.
Your network bandwidth is low.
Hello, is it better?
It is audible, but then the voice is a little muffled.
That's something unusual. Is it better now? Hello. Hello.
You start. Let's see. Don't worry. It's better now, better than before, but let's see.
Yes, I'm sharing the screen again.
Yeah.
So, negative symptoms and treatment resistance. I'll be presenting a case and then we'll try to understand what is happening to this brain. So, a 28-year-old male was brought by family as he was already on treatment from other person and was not improving. He was taken there with the complaints of reduced interactions, impaired self-care, remaining withdrawn, staying in his room for hours, and some amount of eccentric talks with a mixture of spiritual and mathematical themes. He used to believe that we are all simulations in Matrix, and some of the people are actually Agent Smith, which is the antagonist of the movie. He was diagnosed as a case of schizophrenia. He had some positive features, but predominantly negative symptoms. My previous doctor, he was given olanzapine up to 30 mg over a period of 3 months. There was not much change. So amisulpiride was added and it was gradually increased to 400 milligram per day. This led to reduction in the positive symptoms about that matrix and other things. But there was not much change in negative symptoms. In fact, the family noticed forgetfulness and were concerned that medicines are dulling him down further. On elaboration and further detailed exploration, the history was available in the following details was summarized. He was a firstborn, 28-year-old male. Antenatally, mother had history of hyperemesis in first trimester. Other than that, no other complications. Perinatally, he was full-term normal delivery, cried immediately at birth. No major noticeable complications. No issue with learning breastfeeding. But family did notice that he would stay awake at night. He would not cry or disturb anybody, but he would just be awake and playful during the night. Family used to consider him a good child, quiet, and would describe that his presence would not be felt in room. As he grew older, he was a fussy eater at the age of 2. At times, he would refuse food, especially if he did not like a particular food. He was very particular about colors, textures of clothes, etc., and would get irritated, put his hand on ear when people were talking in louder volumes. This may be hinting at sensory processing issues. He was a quiet kid in school, average in studies, had very few friends. He used to like a regular routine, and if the routine was disrupted, he tended to give silent treatment as described by family, possibly hinting at his tendency to withdraw. He managed to study up to masters in commerce. He is good with numbers. But gradually the symptoms started and progressed. Initially, it started as social withdrawal, increased interest in esoteric topics, especially the sci-fi, mathematics, and conspiracies. Patient started staying alone in his room. He would hardly come out, and when family would check on him, he would appear lost in his own thoughts. He had to be told to do even basic things like taking baths, shaving, come to dine. And for about a month prior to visiting this doctor, he also started having odd ideas. Like this whole world is a simulation. He could relate it with the movie Matrix and would believe that the people are simulations too. And the antagonist of movie Agent Smith is there. As those who have watched movies will know that the agent would multiply, and these multiple copies are different people that he meets in his day-to-day life. He would also believe that these people are keeping eye on him. Hence, he was taken for treatment. But there was not much response except the reduction in talk about the matrix. Now, this part was tricky. Whether his positive symptoms actually improved or not, that remains to be seen. Family also reported hypertension in father, Parkinsonism in father's brother, and that father's brother with Parkinsonism. His son used to have nicotine use. No other significant family history of substance use, other non-communicable diseases, or psychiatric disorders was reported. During the interview, he had poor eye contact, low spontaneous blink rate, he appeared lost in thoughts, there was psychomotor retardation, and there was latency in answers. His speech was very little. He would mostly answer in one or two words, and he was hard to engage in conversation. There was very little spontaneous movement. However, on examination, there was no hypertonia or catatonic features. After much prodding, he would report only few lines about metrics, mostly on the lines of, it is still there, but I don't want to talk about it. I'm not much interested in anything now. So what has happened in this case? Developmentally, he displayed some compulsive traits. There is not much evidence of impulsivity in this history. He would have gotten a label like obsessive traits, schizoid traits, or autistic traits over the period of time. As mentioned before, he had issues with overstimulation, which may be hinting at sensory processing disorder. Because he did not have any major issues till completion of education, essentially nobody looked at his behavior very closely. This was partly because of his near solitary lifestyle, and he was, to put it in layman language, not much of a troublemaker. To us, he presented mostly with negative symptoms. Some amount of aberrant salience and faulty deductions, are evident in those symptoms regarding metrics and other things. Positive symptoms may actually have subsided with antipsychotics, or they may actually have been just masked due to the prominent negative symptoms and his loss of interest to interact. So the symptoms that were prominently present are anhedonia, demotivation, affective blunting, asociality, and alogia. Anhedonia was inferred from his loss of interest in nearly all activity. Demotivation was inferred by the description of family that he had to be told to do everything. He was not motivated to do anything by himself. There was reduced expression, which was hinting at affective blunting. There was asociality. He used to stay in his room, not interact with others. And paucity of speech is indicative of alogia. So this is just one figure representative of all the symptoms, how various negative symptoms are correlated with brain regions. If you can see, primarily it is related to frontal lobe. Hypofrontality can be called as a one umbrella term for this. And improving frontal function would have helped him get better. One of the options is dopaminergic agonists like caprizin or epiprazole. Other would be antidepressants and glutamatergic drugs. Given his history, family history of Parkinsonism, dopa agonist would have made sense, but because he has already been labeled a case of psychosis, anyone would be concerned and cautious to use any dopa agonist like pramipexole or other things. As family reported,
Uh, we have lost your audio, Nachiketa.
hello, apologies for the connectivity issue. So essentially, after that, desvenlafaxine,
We don't have your video now, your presentation.
yes, sir, I have stopped the screen share. It was
Okay.
last slide. I'll restart.
Okay.
So rather than risking the connectivity issue, I would just narrate it verbally. It was already about last slide. So after adding desvenlafaxine, it was gradually built up to 150 mg. It started showing response. His expressions improved. His motivation level improved. He started interacting more with families. And over the period of time, the plan is to make him a functional member of society, maybe start some job or something like that. Now, this improvement can be twofold. Either it was related to reduction of the antipsychotics or it was the addition of the antidepressant that worked, or possibly the combination of both. This case also highlights the fact that the overlap of negative symptoms and depressive symptoms at neurobiological level is there. Anhedonia may be a diagnostic symptom and can be present in multiple disorders and may have not been targeted adequately in our clinical practice. Targeting that can actually improve a patient's quality of life as well as health. So let us discuss what other factors we need to consider. What do you say?
Dr. Malay, could you take over?
Yeah, sure. So, Nachiketa,
Hmm.
when we are dealing with cases like this, how would you suggest we assess for yes, you pointed out that there are certain traits since childhood that this patient has along with the family history. Um, when these traits got exacerbated, let's say during the course of his illness or during the course of his treatment, how would you be able to decide, or what are your suggestions for us that are we really addressing the core traits of this individual which have exacerbated, or is it because of the medication that there are certain cognitive deficits that have come up? Is there any clinical way of assessing? Means, do we establish, how can we establish a certain kind of a baseline?
So, sir, the way I would like to approach the case is what detailed history that would give us some idea of what his premorbid traits were. There is family history of Parkinsonism in this case. Other such histories may throw some hints at us as to what may be happening. Let's say something like Lewy body pathology in family or some such. Based on that, we have a rough idea, and we are starting to assess the function and particularly the brain function of this patient. We can look at the functions in terms of various lobes and let's say frontal lobe function. So usually during the MSc also we can observe motivation, positive speech, even we can get to observe evolution also. And then for cognitive part, we may be doing bedside testing like serial suspicion, attention concentration thing, and some basic idea about the previous mathematical and other abilities that are they still up to that level or have they reduced?
Yeah, so no, we'll come back to the case. So that is a general way of history taking. I think when you had presented earlier on about history taking and all that, when we addressed, I think it was here or on another platform, many of the pointers were there. Now, when you're looking at this case proper, see, he did have all these kinds of things. He did have some amount of uh, poor socialization. He would not mix. He was more of a loner. He had more of those fixed routines, so that would need to get fixed, even fixed cognitive patterns, fixed ways of thinking, right? So some things were there, right? Clear cut, you mentioned, as let's say what we would group it as pre-morbid personality, correct? So in this case or in such cases, do you think that when there is so much of this kind of background kind of personalities, background kind of other contributory history in terms of Parkinson's disease in an uncle, do you think it would have been, suppose this case comes to me, first time, with all the suspiciousness and all that, means whatever the presentation was. Now, this, you were probably the second or the third psychiatrist with some treatment being given in the past, which took care of those delusion-like experiences and things like that. But do you think that right from day one, whenever we have this kind of presentation, it would be wise or clinically sound to start an SSRI or an SNRI along with the antipsychotics right from day one? What do you think?
Yes, sir. So there are studies that show, particularly these studies are done in ultra high risk populations, those who are at very high risk of psychosis. When they are given SSRIs, many of them did not convert to psychosis. Now the issue is whether they already did not were not going to progress to psychosis or did antidepressants help. But yes, then there are studies which show that those who are on continued antidepressants they have reduced risk of relapse. So in this case, I would probably have considered adding an antidepressant from day one because his
Okay.
presentation was negative symptoms.
Another way of looking at this kind of patients clinically is that, see, apart from that delusion like idea that all this metrics business and all, uh even in clinical assessment, did you think that it was how would you put it, okay, let me put it this way. See, there were no hallucinatory experiences. Okay, this would be, now if people talk about the matrix, many of us have seen the movie, we know the content. We know that even many people, without having a psychiatric illness, so to say, have a lot of conspiracy-like theory. So it's a part of the thinking overall in many people. So would you label this as delusional in the first place? Because when we have presentations of obsessive compulsive disorder, let's say which are very severe or which would say lack insight and things like that, they would also present with something similar. They might appear psychotic. We may be tempted to start with some kind of an antipsychotic, typical or atypical or whatever we want, because this kind of thinking is there. And when we start, what does happen is that some things improve, but then whatever is the core remains. So then we kind of label it as this thing. So what would be your differential diagnosis in such cases? My point is that.
Okay. That is why this case was considered for the discussion. The first question that we even get in PGs is also differentiating negative symptoms from reflexive symptoms. By and large, it is a physiological or phenomenological differences. One of the things that I was told by one of the professors is that the depressed person would have more subjective distress and would report sad more than this kind of things. Whereas a person with negative symptoms will have less self-report or subjective distress, but family would report more than withdrawn and things. And there would be affective blunting more common in negative symptoms rather than negative features. However, as this particular case shows, patient did improve with addition of distal affection. So are we looking at a continuum of the symptoms?
Okay. So
Okay.
what happened to this patient?
I would like to add something.
Yes, Pastor, please.
The thing is, this question that many of the traditional teachers apply, that negative symptom means no personal distress, and whereas depression means personal distress. Unfortunately, those with typical so-called retarded depression, where there is social withdrawal, where there is very much serious level of disturbance in feeding, habit of themselves, sleep, and other things. There too, they don't say about any subjective distress. So this subjective distress business in negative symptom has to be seriously questioned. This is more of a imaginary criteria to say negative symptom or not, because then every retarded.
I think we lost Bhaskar again. Okay. Yeah. Yes.
We all the network connection is pretty bad. We are joining in and out. Okay. The thing is, so standing there, this way of dividing objectives based on objectivity should not be encouraged. Just continues.
Yes. Again, Nachiketa, are you there?
Yes.
Okay. So, what kind of a follow-up did this patient have with you, and what was what were the changes over the next few months, or how did it proceed?
So it has been roughly 3 months since the first meeting. Initial month took primarily the time was given to reduce the antipsychotics, and at about fourth week or so, the SLR vaccine was introduced. Even by reducing the antipsychotics, that forgetfulness part started settling down. Interestingly, maybe because he is young or otherwise, he did not have tremors or other typical EPS, even with MSL. So that was one good thing. So at that point, I asked the family members, is this the usual picture that you used to see? And they reported, yeah, it is. So in a way, what family wanted to convey is that you are seeing a level of so-called negative symptoms or traits or whatever. Then the antipsychotics came, and over a period of time, they noticed kind of a cognitive delay, which went away, and patient was almost back to his previous level in what we can say antipsychotic naive dysfunctional level, reducing antipsychotics. at that point I thought that just reducing antipsychotics is not going to cut it. So then I added vaccine. And slowly, over a period of time, he started improving. His interactions improved. His interactions with me also improved. Even now, he is not very verbose, but still he would have 3, 4 lines, 5 lines of interactions. And at which point he reports that, okay, I have had certain logics and I have seen certain things. And so that's why I used to believe in it. So the question you ask, whether we call it number one delusion or not, maybe, maybe not. And if at all we call it delusion, I won't call it bizarre delusion. I would call it non-bizarre given the current socio-cultural setup. And then another similar example would be, let's say there are people believing in flat earth, we will call them delusional. So again, the definition part of delusion that not incongruence with socio-cultural context or the belief of family members, that is quite subjective. If you remove that, I would say there's a little difference between this person's thought process and those who believe that. So,
So this patient, let's say from the start of this kind of symptoms to the kind of improvement, let's say till you last saw him, was over how much period? How many months,
about
years?
3 months. About 3 months.
3 months.
Yes, sir. 3 months, yes. Ah.
Anyway, do you think that if this was the kind of response he had, let me put it this way, a very good prognosis kind of a disorder, given his pre-morbid level of functioning, given his varied family history? So this becomes a kind of a very fluctuating kind of a syndrome with a mix of different groups of symptoms across various disorders, which kind of responded very fast to a primary drug as well as whatever you added later on and the changes that you made.
Yes, sir. So there are chances that this case would get different level across his lifespan at different points of time. He would always have this kind of mixed presentation. There would always be debate whether the first psychiatrist diagnosed it correctly or second one correctly or third one. It can be diagnosed as MDD with psychotic features, or it can be even diagnosed as a mixed case of autism with on and off symptoms. But personally, what I have seen, I would believe that he will require long-term treatment, maybe lifelong, with one antidepressants, and I would expect flare-ups in between. These flare-ups can go into obsessive side or probably frank psychotic features also. He would probably have tendency for some amount of hypervigilance, but then he tends to withdraw. So I have yet to assess it in detail. Given that, I would also consider possibility of development of Parkinson feature in future and probably even dementia due to the family history of Parkinsonism in uncle.
So there are
Yes, sir.
two questions. Malay
Yes.
bhai probably.
Yes. So Rajkumar sir has asked 2 questions. I would
Which
try to
one
address
is
it.
Rajkumar sir? Too many IR Rajkumars. RI IR Rajkumar too many. My question is, am my screen getting this kind of thing, or everyone is getting this kind of things? Is this a network problem, or this is my phone's problem?
Possibly network problem.
Or okay.
I am stationary right now, so I think it's from the network side only. Hello, am I audible?
Yes, sir, you can carry on.
Yes, you are audible.
Yeah, so I'll try to answer the things at my level and then hand it over to Bhaskar sir and Madhvi sir. The one question is, instead of adding SSRI or SNRI for negative symptoms, how about adding clozapine with hemisulfuride? So, sir, the thing is, why would I add clozapine? I mean, how would I justify adding clozapine just because it is labeled as a treatment resistant case with predominant negative symptoms? Maybe one of the dictums that we were taught in PGC is to reevaluate the diagnosis. But over a period of time, when I have started realizing that it is ultimately just a descriptive diagnosis and list of symptoms, then I am trying to understand what is happening at brain level before adding a medicine. And with regards to the symptom profile, he was already, I mean, family already reported some amount of cognitive dulling after increasing antipsychotics. So my line of thought was that piling upon that would actually slow down cerebral metabolism even further. And that may actually worsen his so-called negative symptoms or secondary negative symptoms. With that logic, I started antidepressants. To be very frank, I did not expect this fast of an improvement. The second question is, could this have been post-schizophrenia depression or post-psychotic depression? No, sir, because even though patient started improving, his report of symptom was not typical depressive symptoms. At the same time, he did not report any subjective distress or any other features with regards to having that psychotic features. So I won't call it post-psychotic or post-schizophrenia depression as of now. And then the family is also describing that those symptoms, whatever they are, be it negative or depressive, they have been there before and they are there now also. So it's not like patient developed a psychotic episode and then went into depressive symptoms. Over to Bhaskar sir and Malaysia.
Okay,
Yes,
let
yeah.
me answer this question. Then Malay Bhai would also give you his answers. First is adding clozapine and amisulfuride. There is no logic at all. There is no single logic of adding clozapine to this patient because the patient actually had no symptom that said that in this patient no drug is working. Number one. Number two, the patient has no symptom of any adverse effect to any of the ongoing and so-called antipsychotic. So that why should we add clozapine? Specifically, clozapine with its own use in various psychosis with resultant increase in obsessive compulsive symptom. What the patient is complaining more of a obsessive compulsive nature. So by using clozapine, we are actually increasing the chances of obsessive compulsive symptom more. Number two, amisulfuride. What would amisulfuride do? Is low dose amisulfuride for negative symptom is a medical myth. Most of us tend to actually douse the patient with antipsychotic whenever we get a psychosis. The usual dose I see in a psychosis patient is like 8 to 10 milligram of risperidone, 5 to 6 milligram of aripiprazole, sorry, 8 to 10 milligram of risperidone, 10 to 20 milligram of olanzapine, along with that 100 to 300 milligram of amisulfuride. I don't even understand why so many antipsychotics are going on. Nobody tells that in negative symptom, antipsychotics work. What the original research data showed that in second generation antipsychotic or so-called SDA antagonists, the chances of medication-induced negative symptom is less due to aggressive medical marketing that resulted in psychiatrists prescribing this drug for negative symptom. There is no scientific basis for using 100 mg or 200 mg or 300 mg amisulpiride in negative symptoms. That first psychiatrist has to know. Psychiatrist has been doing this blood test for decades now. So in this patient, giving clozapine with amisulpiride has no scientific merit. Now, post-psychotic depression. What is post-psychotic depression? Can anyone in the psychiatry world show me a case of post-psychotic depression which was not there before bombardment with antipsychotic, which was not there before onset of psychosis, and which was not there throughout the life of the patient? If anyone can show me a depressive episode fulfilling these three criteria, then we would talk about post-psychotic depression. We psychiatrists are too non-thinking. We don't think at all. We just prescribe. We just ignore the cerebral cortex. We work via spinal cortex. Whatever was told by teachers, whatever was told to us during PG days, that remains sacrosanct. We deal on axioms. We don't even question. Kane in 1988 published that clozapine is the best drug, and we are still doing that in 2024. No replication, no criticism, nothing. Someone did it, we would follow it. In whose study, again, in before 2000, there was a study that some developed country has poorer uh, prognosis in some schizophrenia. That has become sacrosanct. That has become golden rule. Now everywhere we talk that developed countries has poor prognosis of schizophrenia. Has anybody gave any second replication study citing the same thing? Has anybody talked about this? We psychiatrists we are just running our world on axioms, sacrosanct truth that never can be questioned, that never can be proven. So standing there, post-psychotic depression has no meaning itself. Why should it be post-psychotic depression? Now, if we take your judgment that yes, there is a post-psychotic depression, it is a post-psychotic period. This patient is still in psychosis. So have to learn to critically think. I know telling people think critically has no effect on their critical thinking, but at least pause and think: Am I right? Am I doing everything good? Am I doing everything that is needed to cure a patient? We should at least, uh, we should at least question. Over to me.
Yeah. So when we are looking at psychiatric illnesses as we are trying to understand on a brain basis, then what comes before, after, as a result of one another, we should be very clear about. So when we are looking at post-psychotic depression, we need to wonder whether it is there before or not there. Otherwise, with this, we would probably be labeling a bipolar depression as post-manic depressive disorder. So it's not like that, because most of the patient who have primary psychosis, if you would like to call it that, don't necessarily have post-psychotic depression. It happens in some people. So if it was a rule that it has to happen, then it should be seen in each and every patient, irrespective of the treatment, and so on and so forth. So what we are trying to do here is try to understand that how things work differently in different individuals. Uh, it can also happen that in a patient which was in a patient like this, which Dr. Nachiketa presented today, that when the psychotic part would get clear, he would have more of those baseline OCD symptoms coming up. We do not say that it's a post psychosis OCD re-emerging. So we need to look at what is actually happening in this patient. If we go by criteria or if we go by fixed constructs, we would, somebody has asked how to look at resistance. Dr. Om Prakash Bedekar asked how to look at resistance to treatment. It means that you have tried one drug from one category, second drug from a similar category, third drug from a similar category, and then you have kind of hit an obstacle. Nothing much is happening beyond that. So basically, resistance to treatment, if we look at criteria and if we look at guidelines, it means that we have tried only one kind of, one kind of a mechanism of action, and we are not getting to that. This will happen if we look at a fixed construct of what is schizophrenia. If we look at DSM-5 construct, here we are not trying to look at those constructs. There is ample evidence to prove that DSM-5 and ICD-10 are not completely addressing what our patients are experiencing. So as clinicians, it is important for us to kind of delineate as far as possible from first day itself what is happening, what are the symptoms, and what could probably be happening in the background of the symptoms in terms of etiopathogenesis. That is when the concept of resistance seems very shaky. Dr. Rajkumar asks, is NSE useful in addressing oxidative stress? No. All these are kind of supplements, and if you're going to use them, probably these are not the doses that are given or prescribed as guidelines. They are not going to be very effective, and in fact, it will not be useful in most patients, except being a kind of a costly supplement or an add-on molecule. I think what we can do now is we can go to the second case and let's see what more we can discuss in them.
Dr. Malay, just like to bring to your notice.
Yes.
All the names are only in all the questions are in my name, but it is not me. Everyone else is adding. Somehow today, all the registrations are coming only in my name. I'm sorry about that.
I don't understand. What is happening?
Some technical fault, perhaps.
Yeah. No problem. So, I mean, if it's your name, we'll take your name, and then you can pass on the answer to whosoever is hiding behind that name. So anyway, we'll go to the next case now.
Sir.
Yes.
Yes, the next case, I have to do it myself because Vaibhavi could not attend today due to some personal emergency. So I would narrate a case because the thing is I could not make a presentation on a very short notice. But if anyone want, I can actually produce the prescriptions because I have all the prescriptions of these patients. Anyway, this is a patient that was referred to me by a institution out of West Bengal. This patient was referred to me because the patient had reached a block after full dose of clozapine, after full dose of amisulpiride, after full dose of almost all known antipsychotic. The patient was not getting well. Along with every symptom, the patient also had severe level of globus and patient had 2 episodes of seizure. So giving him further antipsychotic was becoming a deadly choice. So he was referred to me to find something that is out of body. So when I started seeing the patient, the first thing I saw is patient had unusual. This is a first patient whom I saw who has my same 6 feet 6 inches. But unlike the height the patient has very keenly built. Patient had prominent marfanoid stage. This was the first tracking point that I got. Then in childhood, when I started taking childhood history, I found that patient was very reserved in early childhood days. There was no developmental delay, but during childhood, there was multiple phobias. There was school phobia, which later developed into examination phobia. And then around adolescent age, patient also had severe migraines and had to take treatment for it. There was some stuttering which went away when patient was in college of, and around second year of college, he started developing first increased fearfulness, followed by suspicion that people are talking about me. Then he started hearing voices berating him, a single voice. Then he started developing social withdrawal and also a lot of obsessive rituals. And ultimately, he became housebound. He was taken to multiple psychiatrists and he has been prescribed 900 milligram clozapine. He has been prescribed 800 mg amisulfuride. He has been tried up to 8 mg risperidone. Then he has been tried with lamotrigine. He has been tried with valproate, and also people have tried various nutraceuticals on him. But ultimately, he became socially withdrawn. Still, alternate health situation was continuing, as well as patient had stopped interacting with everyone and was living on minimum diet. Patient had family history of similar illness in father's side. Two of father's cousins developed it, and father's younger brother died after which was taken by suicide. In mother's had severe obsessive compulsive personality as well as recurrent depression and other. There was family history of uncontrolled diabetes, but fortunately our patient was not diabetic. There was also family history of multiple other non-communicable diseases in the family. So when I started seeing the patient with so many medication, my first question was, what is happening to this patient? So I first tried stopping the medication. Patient was getting 800 milligram amisulfuride, 900 milligram prozapine, and along with alproate and lamotrigine. I stopped. Then I stopped alproate. Then I started giving memantine. Went up to 20 milligram. Felt slightly, but was the patient's mood was slightly better, but the voices and social withdrawal and everything remained the same. Then I stopped amisulfuride in two steps. First went into 400, directly omidolate. Then after 2 months, actually patient was a bit better, less complaining of globus, less complaining of irritability, less complaining of low mood, but the voices were still there and the other things were still there. Then I started him on paroxetine because of associated palpitation and associated anxiety. And I started using clozapine. First was on 900, I reduced it to 700, then 500, then 300, then 150 over one month interval. Each reduction was done over 1 month interval, and finally 100. He started improving, started socially interacting more, started getting less and less voices, started feeling himself well, started ultimately going out of house, started joining society. By now, 1 year has been gone, and I was courageous enough to finally stop the clozapine and start olanzapine 5 mg. With this, the patient was better. Along with olanzapine 5 mg, he was taking paroxetine 62.5 mg, propranolol 80 mg, and along with that, memantine 40 mg. With this dose, his social withdrawal is gone. He was talking freely. He is now taking care of his parents, doing the household job. As he is now 47, he cannot get much job except maybe a shopkeeper, and his parents and his family members are trying to put up a shop for him so that he can earn his own living. This is now 1.5 years of his treatment, and he is stable on paroxetine 75 along with 80 milligram propranolol. I have not been able to reduce olanzapine 5 mg. Whenever I reduce olanzapine below 5, his irritability starts increasing and his restlessness starts increasing. And he is now taking memantine 14 with SOS melatonin if he doesn't get sleep. The melatonin dose of him is 20. So this case probably again is a evidence of our indiscriminate reliance on clozapine and our misunderstanding of whole psychosis, treatment resistance, and negative syndrome. Probably this was a missed high functioning autism who later went on and developed destabilization during early puberty, and then he developed more and more into obsession predominant psychosis where he was piled on with drugs which increased his obsession, and ultimately we got a treatment resistant schizophrenia with severe anxiety, and his patient was only dead. There is a right? Times kicked out the whole meeting, and it is some technology which is a
I think we have lost Bhaskar once again.
His connectivity is a little on the low side.
No, I think today we are having more technical issues from
Yeah.
the Zoom side rather than our this thing. Because if most of the people are able to,
Sir, your internet connection is perfectly. Your audio video is perfect, sir.
Yeah.
yeah, no problem, whatever. I think this is happening with people who are, I always use my laptop, so I don't have any issues there.
Yeah, I'm using my desktop,
Yes.
so even
Yeah.
Rajkumar sir voice also very clear.
yeah.
Internet is your backbone.
That's true.
If your internet is good, your audio is perfect.
There he comes
Today,
back.
the internet is hugely. Yes, I'm back. God, there are so much speech.
Yeah. So, can you, Bhaskar, give us uh, a very brief summary because there are a lot of disturbances. There was a lot of disturbance in your audio, and I think we lost you once or twice. So, just can you
Yes,
tell us in brief?
yes.
Uh,
The thing is,
just
this is a patient who was on high dose clozapine,
hmm.
amisulpiride, valproate, and along with that, lamotrigine because of severe auditory hallucination, severe anxiety, severe globus sensation, as well as severe form of social withdrawal, social, occupational, and even he started withdrawing from daily sustenance. This patient was sent from a institute where they write a roadblock and they could not do anything because on further increase of antipsychotic there is seizure. So I stopped all antipsychotic as well as anti-epileptic gradually. Started him on memantine and paroxetine, and paroxetine I went up to 2.5. Memantine I went up to 40 mg, and along with that I stopped all ongoing antipsychotic over a period of 1 year, and I gave the patient only olanzapine 5 mg, and he was doing well and still doing well on this regime. And now he is free of most of the symptoms, doing things in family well, doing things in personal life well, but there is no occupational recovery because he is now 48 and he has lost almost 28 years of his life due to this illness. He is now being tried for rehabilitation in form of shopkeeper.
Okay. So again,
So this is the
yeah. So I'll ask you the first question. We'll wait for more questions to come on the chat. Uh, like I asked Nachiketa during his case, the same question I'm asking you that this kind of what is the time frame onset of symptoms to this kind of improvement? I mean, of course, he has visited a couple of psychiatrists in between with all
uh,
this. So, what is the total
onset
time
of
frame?
symptom.
Huh.
Onset of symptom was in his 21st year, second year of college.
And now he's
And
47,
he
48.
48.
Okay, so 16 years now.
And I am seeing him for last 1.5.
So the maximum improvement, I mean, after being labeled as resistant or whatever, is in the last one year or so.
Last 1 year, and he was on every antipsychotic, every antibiotic, and every pharmaceutical. He is the first patient in whom I saw the respectable dose of N-acetylcysteine being used. He has been prescribed by our institute 6400 mg N-acetylcysteine, which is a really respectable dose.
Okay. Okay, so we have one question from Dr. Vishal Sinha. I think he's the original Vishal Sinha because he doesn't have any other name. How can we explain auditory hallucinations responding to paroxetine?
Because, sir, as I have started with the neurobiology of positive symptom in my psychosis series, of the which series this is the penultimate episode, that auditory hallucination is nothing but misrepresented auditory imagery. And auditory imagery comes from rumination as well as sensory misprocessing. Antidepressant, memantine, low dose antipsychotic, they correct this misrepresented auditory imagery more quickly than any antipsychotic at high dose. Rather, at high dose, antipsychotics causes suppression of the auditory imagery formation, and the patient goes more dumb, more dull, and ultimately, in many of them, there is reverse increase in auditory hallucination. And that is what has happened in this patient. In most of the chronic patients, in whom there is no acute aggression, whom there is no violence, we would find that antidepressant actually works much better on hallucination compared to antipsychotic. Why we need antipsychotic high dose? Because of the initial aggression, initial violence, initial destruction. But once we control that, antidepressants become more of a treatment than only antipsychotic.
Okay. Fine. Do we have any other question? So Dr. Vishal Sinha continues. What about the risk of activation in such
The
patients?
risk of activation only happens those who are prone to activation. How can we understand who are prone to activation? Those who have high heart rate, baseline high heart rate. Those who have a baseline heart rate around 90 to 100, they or more, they would have more chances of activation. Then those who have other autonomic symptoms like irritable bowel syndrome or other autonomic symptoms in form of recurrent nausea and vomiting or autonomic symptoms from a frequent panic attack, they have a more chance of activation than other patients. So in them, we should increase the drugs slowly. Let's say we are giving antidepressant. In normal patient in whom we are suspecting there is less chance of activation, we can increase the dose every 4 to 7 days. In these patients whom we are suspecting that the chances of activation are more, the ideal dose should be minimal increment every 10 days to 14 days. Let's say I started paroxetine in this patient. I pushed that paroxetine dose from 12.5 to 67.5 over a period of 3 months. Extreme slow, because I never wanted this patient to have a activation symptom. And I know we actually don't go slow like that. But if we go slow like that in patients, it is easier to push to high dose. It is easier to maintain them on higher dose, and the chances of activation and treatment-induced affective symptoms are very, very less. Most of the patients who gets unfortunately stamped by bipolar 3, manic switch, and things like that, in them, we have not given adequate protection against sympathetic activation, that is adequate coverage with either propranolol or clonidine or things like that, and we have given them pretty fast. The third question of SARS is, if activation happens, yes.
Should one reduce antidepressant and increase dose of antipsychotic, or how would you go about that?
If activation happens when I start doing this type of antidepressant induction, I pause the antidepressant there. Means I continue the dose of antidepressant that was going on. I don't risk hiking for some time. I increase the dose of antipsychotic one notch. Let's say patient. I am giving an example of olanzapine. The patient's dose of olanzapine is 10 mg at that moment. I increase it to 15 mg for 1 month, and along with that, I increase the dose of propranolol or clonidine if I am giving that, or if I am not giving that, I would introduce that. That would sort out TS in most cases. And in case of insomnia, giving benzodiazepine is also very effective.
Okay, my question here before I take the next question is why did you, in this case, choose paroxetine and not any other SSRI?
Simple. We could have chosen a lot of things, but his nature of illness, that is, the symptoms said high palpitation, globus, extreme globus hystericus, he couldn't even swallow anything, and along with that, severe obsessive rituals and behavior says that I should give something that is less of an activating nature. Now, whether one drug would be activating or non-activating would depend on patient's genetic makeup. But generally, escitalopram, paroxetine, and vilazodone are less of an activating nature rather than fluoxetine or other drugs or sertraline. That is why I started paroxetine there.
Okay, so again on
That
that,
is a educated guess estimate.
okay, but
There is always
yeah,
a chance that
yeah, that's
patient
true.
given
That's true.
paroxetine would show more activation.
Oh. Can you tell us these three molecules, at least which you mentioned right away, paroxetine, escitalopram, and vilazodone? What is their reason for being, or what is their mechanism for being more kind of
Sedative.
non-activating compared to the other ones?
More non-activating.
Yeah.
There comes the catch. To be very honest, I don't have any evidence of them having unique mechanism of action that calms patient down. I can say all of them have stigma action, but fluvoxamine also have stigma action. All of these four have stigma agonist action. So that would say I am just creating an intellectual facade. So I would not say that. I can
Okay.
also say that all of them have actually more favorable action on notch pathway. They are notch suppressor. But again, all of these are the drugs that have evident notch pathway action. But all the other drugs, they have their notch action. So how can we at this moment say that this drug is doing this because of that? I'm not
Yes.
sure. So I would say I don't.
Okay. Question by Dr. J. Sarvanan. Is there any use of newer drugs like cannabidiol, cariprazine, endoxifen in patients with predominant negative symptoms and treatment resistance?
But let's stop this predominant negative symptom and treatment resistant part, because treatment resistant doesn't exist. We make that a name because we follow guidelines. There are thousands of patients in my own patient record who has not responded to olanzapine, has not responded to clozapine, has not responded to haloperidol, but then responded to iloperidol. So, is this patient treatment resistant? It is not. One patient I can give you example. Patient was stamp treatment resistant by Niemann's itself. Niemann's gave the stamp treatment resistant. Patient was termed super refractory schizophrenia because patient took up to 500 mg clozapine and didn't improve. Then I myself have tried iloperidol on that patient. and patient responded beautifully to iloperidone, so much beautifully that patient stays well with 6 milligram iloperidone once a day only. Does that make iloperidone a superior drug than clozapine? No, it does. It just says that our definition of treatment resistant is very one-sided and non-scientific. Each drug works differently, and there would be some patient who would be more responsive to one drug, less responsive to other drug. If a patient is showing treatment resistance, then probably we should think that we have not tried drugs enough. So let's drop the names. Now, is cannabidiol good in case of withdrawal symptom? Actually, cannabidiol is a drug that is more useful for people who have high level of brain activity. So people who are dancing, people who are let's say, actively hallucinating, people who are aggressive, people who have epilepsy, people who are severely restless. In them, cannabidiol is a more good apt choice rather than patient who are withdrawn. Similarly, cariprazine is a drug that is actually activating. Cariprazine at lower doses might help in so-called negative symptom in comparison to clozapine, in comparison to olanzapine, but in comparison to antidepressant, it might not be that much. So there comes a relative efficacy. So relative efficacy wise, cariprazine might be better than olanzapine, might be better than clozapine, and might be at par with aripiprazole in case of negative symptom. But comparative to various other drugs, it might not be that. It all comes down to what we give and what we don't.
Endoxifen.
Endoxifen is a drug that works in certain parts of brain activity. It controls any kind of sudden part of brain activity. Not only endoxifen, this is hallmark of any kinase. Any kinase would stop sudden paroxysmal activation of brain. So be it endoxifen, which is tyrosine kinase C inhibitor, or be it any Janus kinase inhibitor, they would stop sudden aggression. They would stop various kind of compulsion. They would stop various kind of impulsive compulsive behavior. But for them to control a patient who is predominantly withdrawn, predominantly stopped responding to outer world, would be very dubious.
Okay.
If we give long term, then might be the kinase pathway that they are inhibiting would become hyperactive and do it. But that is a speculation.
Okay.
And
So,
at this moment, the speculation is too much, so better not do it.
okay. So I'll make one comment here and I'll ask a question to you. First comment
Hmm.
is, see, when those who coined the term, treatment resistance and things like that, terms which we are not very happy with, there are other people who also coined terms like clozapine resistant psychosis. So, I mean, that's fine. We give them some credit that clozapine is not the final molecule. There can be other things like what we said. So that was my comment. And the question uh, is there any way, clinical way of assessing who may be a poor responder in the long term? Because that would save us a lot of sweat. We might be able to uh, be, more specific in
Exactly.
treating them.
The best example would be a person who has high functioning autism trait, a person who is very anxious, shows recurrent depression trait, who is very restless, and who has social deficits. These are the people who can be sure to show poor response to antibiotics.
Okay, right. Uh,
Old people people who are previous generations, they have actually noticed it. And there are some old books who say that in people who had deficit theory of mind, in them, antipsychotic works less. This was a purely observational finding. They have observed it, they found it, but later this knowledge of theirs got overshadowed by this guideline formation and other things. In people, let's say in books of 1950s, 60s, there are some this kind of observations. When I was studying history of psychiatry, I found this comment.
So, do you think there was that old concept of Crow's schizophrenia type 1, type 2, with some presentational changes? Some, I mean, that time it was CT scan or even before that. So it was more of observational.
Before that, more of observation.
Yeah. Okay. So another question comes from from Dr. Nachiketa, and his question is, any comment on biotype 3 of B SNPs and cannabis use?
I would say biotype 3 of B SNPs is a very volatile category. The people who have started B SNP study in B SNP 1, after B SNP 2 study completion, they have started saying B SNP 3 is a artificial category and long-term follow-up. All of them are shifting to, or most of them are shifting to either type 1 or type 2. So standing there, it is very hard to say whether this volatility is due to cannabis use or due to them being early stage or due to them being various other. We don't have much data to say whether this is cannabis use or not, but cannabis being a trigger factor for this type of psychosis, we may speculate that they might have changed due to cannabis. But I would take that with a pinch of salt because they are in a study population and I don't imagine they having access to any addiction.
Okay. So, Dr. Karishma asks, we have seen that schizophrenia with OCD symptoms could become clozapine resistant. So, what do we do?
OCD symptom means first think, are we dealing with schizophrenia with OCD symptom or are we dealing with a high functioning autism patient who which else who is finally developing into this type of thing? We have to first question ourselves because that is what happens generally. In there, these patients are naturally resistant to clozapine, rather they are people who would show more obsessive trait with while on clozapine. If we suspect that, we should not give them clozapine. Treatment-resistant schizophrenia doesn't exist. What we exist is a various symptoms which are not responding to various drugs. So standing there, if person is already predicted that this person is developing, would go on developing more symptom with clozapine. So why give them clozapine? Give them olanzapine, give them amisulpiride, give them risperidone, but risperidone has a chance of making the patient dumb. Give them aripiprazole, give them something else. Do not start them on clozapine. Clozapine would make them worse. I have had misfortune of seeing too many such cases. Due to my unique work experiences and due to my area of interest, I see this type of patients too much, where clozapine abuse is a kind of entity. Patients who do not need clozapine gets clozapine. Yes, clozapine is underused all over the world, but unfortunately, I see abuse of clozapine. So
Okay.
don't give clozapine in this type of patient.
Another question that has come up is there any relationship in this patient, the one which you presented, between severe globus and disease psychopathology?
Globus is a kind of compulsive oropharyngeal spasm, which once happens, patient gets discomfort. So by this globus alone, patient says that patient is having a compulsive background. So why by that feature alone, patient is saying that patient doesn't need any form of antipsychotic higher dose and patient needs more of a antidepressant. So globus is actually very, very interesting in this patient.
Okay. I think we have covered all the questions, and we have been talking and discussing for more than an hour, and of course, with all the technical issues and all, I hope it is better next time. Thank you,
Yes.
Dr. Bhaskar. Thank you, Nachiketa, for the cases and the discussion. And thank you all for being here, and thank you for all the other names that you got in spite of being there. With that, I hand over the proceedings to Dr. Rajkumar.
Thank you, Dr. Malay. I thank Dr. Bhaskar, Dr. Nachiketa, and all of you who have participated. I'm sorry for the glitches that have happened. We'll try to take care that it doesn't get repeated. We also thank the knowledge partners, Alchem CNS, for this session that we are having. And we hope to see you again a fortnight later. Good night to you all.
And a fortnight later, we would have our last session in psychosis series, the real pathophysiology of mania and neurobiological rejection of mania. We would not have a treatment period of mania because the treatment part we have already covered in positive and negative symptom psychopathology.
Yeah.
Oh,
Okay. Good
thank
night to
you.
all of you.
Thank you, and
Good
good
night.
night.